Okay, so this is the orthopedic wellness, bone and joint orthopedic wellness class for you to go through. And we're just going to go over how to prepare the week before your surgery, how to prepare the day before your surgery, what to do what happens the day of your surgery. We're going to hit on the anesthesia plan. We'll go over a little bit on the pain control plan. I'll talk a little bit about physical and occupational therapy and nutrition to fuel your recovery and discharge planning. And then rotating through the stations, after I finish, physical therapy is going to be coming in to talk to everybody, and social workers are going to be coming in to talk to everybody. So we want you to know that recovery from orthopedic surgery is a process. It takes time, it takes patience, it takes help from your family and friends, and sometimes it takes everything you've got. And we're here to help you to get the best outcome that you can. So the week before surgery at home, you want to, in your kitchen and the most used rooms in your house, you want to place your items at arm level so that you're not reaching up or bending down to get things. Make it nice and convenient, maybe a little messy for a couple weeks, but it'll make it easier for you. The use of a long-handled shoehorn or a grabbing device is sometimes helpful. You want to rearrange your furniture, any throw rugs that you have, so that you can get safely around with a walker, because you're all going to go home with a walker. So you want to make sure that you can navigate through your house with the walker so that you don't trip over anything. You want to repurpose the room on the first floor. If you've got a bi-level house, you want to repurpose the room on the first floor so that you don't have to go up and down, a place where you can rest during the day. You want to set up a command center. You want to have things available for you. You want to bring a phone, your medications that you might need throughout the day, water, any refreshments that you might want, any TV remote or books or anything that's going to keep you occupied during the day. So the week before surgery, you want to pick a chair, and you want a firm chair. These chairs are kind of firm. That's the firmness you want, but you want something a little higher. If you have a recliner that you're planning on using, and it's kind of low, you want to put a cushion in it, or like fold up a blanket, something that's going to keep your hips up so that you're not sinking down in it and making it harder for you to get out of the chair. You want to if you have a bi-level house, and you want to make sure you have handrails on your stairs going up to the second floor. You want to make sure they're nice and sturdy. You want to make a plan for any small pets that you might have, because I have cats, and even without a walker, they're all over my legs and my feet. And you want to make sure that they're not going to trip you up. So you're going to make plans for them. It's very important, and that's why it's in red. Make sure that you don't shave around the area, your knee or your hip, for 7 days prior to surgery. Because what happens with that is shaving causes they call them microabrasions. Little abrasions so small that you can't see it, but they're prime areas for bacteria to get into. Any bacteria that gets into your system with a new joint, it goes right for that joint. Do your best to avoid any open areas, scratches, pet scratches, bug bites, or sunburns on the surgical area. I work sometimes up on the ambulatory, and I've seen people that were postponed. They had to go home and come back another time because they have these things. Any small area, I saw somebody that was canceled one day because they had a little white pimple on the area that the surgery was at. So anything unusual, let your surgeon know. So your pre-op visit, just before your surgery, the doctor's going to e-script in your medications to take after your surgery. That's so that you can pick them up that day, so it's more convenient for you, so that you don't have to pick them up on your way home from the hospital. But remember, those are for after your surgery. Don't take them until after your surgery.
When will you get those medication prescriptions?
On your pre-op visit just before your surgery?
Yeah, my surgery's scheduled for a Monday, so would I get them like tomorrow?
Is that when you're having your doctor's visit?
Yes.
Yes. They'll e-script them in that day, and you can go to your pharmacy and pick them up that night.
Okay.
Okay?
Yep.
But just make sure that you know that's for after surgery.
Okay.
Okay? Have you all gotten your scripts for physical therapy and any kind of adaptive equipment, walker, that you've all gotten those? If you haven't gotten those, you need to speak to your surgeon's office. Yeah, you need to talk to your surgeon. Physical therapy, if you're planning on outpatient physical therapy, today you need to call and make your appointment for your outpatient physical therapy. That means if you're going to go to a facility in the community, you want to call them today to set up your first appointment, because they fill up quite fast, and you want to make sure you have your appointment so that you can start your physical therapy, your outpatient physical therapy, like 2 to 3 days after you get out of the hospital. So call today. Even if you don't have your script, you can tell them what you're having done, when you're having it, and then they can set up an appointment for you. The day before surgery, you should pack loose pajamas, baggy shorts, short nightgown, or a short robe that will fit over surgical dressing. And you want to make sure that it doesn't come below your ankle, because you don't want anything that's going to trip you up when you walk. You want to bring in some flat supportive athletic or walking shoes that are non-slip, so that you're able to navigate through the hallways in the hospital without tripping. You can bring some personal toiletries. They have some body lotion and they have soap, but if you have your own special stuff that you like your own toothpaste or your own soap that you like, you can bring that in. But don't bring any colognes or any heavy perfumes, because you yourself after surgery are going to be a little sensitive to those kind of smells, and other people on the floors might be very sensitive to those things. I would suggest bringing a small bottle of hand sanitizer so that you can put it right on your bedside table, your bedside stand. Every room has one of those big containers of sanitizer, either on the outside or right inside the door. But there might become a time when they bring breakfast and you're not quite out of bed and you just want to, wash your hands. You have that sanitizer right there. Bring in eyeglass. If you wear eyeglasses or contacts, bring in a case for those. And dentures, also you can bring in a case. Make sure you label those. Not to worry though if you forget them on that day. We always have denture cups here on the floor. And if you forget your eyeglass case, we have these handy dandy eyeglass cases. They're called gloves. You just slip them in there so your lenses don't get scratched if you happen to forget them on that day. It's always good to bring your own cases though. Hearing aids, bring a case for that too. You know how expensive those things are. You want to have a case and you want to have it labeled because you don't want to lose those things. You want to bring a list of telephone numbers, or for those of you that have a cell phone, they're already programmed in there. I don't remember anybody's phone number anymore. It's all programmed into the phone. So you want to bring that list if you don't have a cell phone. They have phones on the floor that are free for local calls. You can't call China or Timbuktu, but you can call local if you have anybody local that you want to call. Bring that total joint guidebook with you. So if you have any questions with you after your surgery, you can look in that book. If there is something in there that's not, if you have a question that's not in that book, that's not addressed in that book, just ask your surgeon, your physician's assistant, or any of the nurses on the floor. They can give you answers. If they can't, they can find out for you. Bring a loose sweatsuit or loose comfortable clothing to wear over your dressing upon discharge. If you have a healthcare proxy or a living will, make sure you bring one of those in, and we can copy it, or you can make a copy at home and bring that in. We'll put that in your chart for the time that you're staying here. But we ask you not to bring any valuables, jewelry, purses, wallet, cash, credit cards, any jewelry that belonged to your great-grandmother, anything that you would be very, very upset if you lost, because things get misplaced in the hospital, and sometimes you get moved from one room to the other, and you don't want anything lost that's really important to you. So the day of surgery, midnight on that day, you can't eat or drink anything after midnight on that day of your surgery. You can have a small sip of water with your allowed medications, and when you went through pre-admission testing, there's a spot on there that tells you what medicine you can take on that morning. Only those medicines with a small sip of water. You can brush your teeth before surgery, but remember, don't swallow anything. We don't want you to swallow something and then have anesthesia, everything's relaxed, and then it comes back up, and then it goes in your lungs, and then you have this really bad pneumonia. So nothing to eat or drink. If you are on any prescribed blood thinners, such as Plavix, Coumadin, Xarelto, Lovenox, Eliquis, and I see any number of ones out there like Brilinta, I've seen that advertised. You need to talk to your prescribing physician as to when or if they want you to stop those before surgery. Also, NSAIDs, which are prescribed NSAIDs, are like Nabumetone, Celebrex, diclofenac, Voltaren. Those types of medications, and any over-the-counter and non-steroidal anti-inflammatories, like Motrin, Advil, Aleve, those types of things, and fish oil are usually stopped 5 to 7 days, and those should have been addressed on your pre-admission testing form. If you're diabetic and you take any injectable insulin, or you have an insulin pump, make sure you talk to your prescribing physician as to the dose of your insulin before surgery. Usually it's cut in half, but that you just follow whatever the instructions your doctor gives you. Then again, remember, on the morning of surgery, you can take those medications as you normally do with a sip of water. And I know some people take their medications with milk. Some people take their medications with applesauce, but on that morning, just a few sips of water. Those medications usually include any prescribed pain medicines. If you're having some discomfort before you come in, definitely take your pain medicine before you come in. Also includes any anxiety medications, psychiatric medications, cardiac medications, and certain blood pressure medications also that they let you take in the morning of surgery. So that pre-admission testing form is very important. It's got a lot of good information. You just follow the instruction on that sheet and you'll be doing good. If you have sleep apnea and you use a CPAP or a BiPAP machine at night, you need to bring that into the hospital with you on the day of surgery, because one, if you have sleep apnea, you've already got a compromised respiratory system, and two, if you throw in some narcotics for pain on that, it decreases your respiratory system even more. So that's why they want you to bring that CPAP or BiPAP in. So on the day of surgery, well, actually, the evening before surgery, if you're having surgery on Monday, this Friday, they're going to call you with the time that they want you to come into pre-admission testing. If you're having your surgery on Tuesday, they'll call you on Monday between 3 and 6. If you're having, some people have their surgery on Thursday, they'll call you Wednesday between 3 and 6. And they'll tell you what time to come in to patient registration. Don't come in any earlier, because the time that they tell you to come in gives us time for you to come up to the 3rd floor, for us to do all the things that we have to do on ambulatory before they send you over to the operating room. And if you come in, I know a lot of people like to come early so they're not late, but if you come in any earlier, you're just going to be waiting longer upstairs. So you're going to come in through the main lobby over here. You probably all have been to admissions at one time or another for a test or whatever. So you turn to the right. It's the first right-hand door down this little hallway. They'll get you admitted. They'll put the bracelet on your arm. Make sure you check your bracelet. Make sure that your name is spelled correctly. If you use a middle initial, that the middle initial is correct, because I'm a Linda Brown. There's like 20 other Linda Browns in Columbia County. Some of us use our middle initial, some of us don't. So make sure their name is correct. Make sure that your birth date is correct. When all that's done, they'll send you up to the 3rd floor, which is the ambulatory pre-surgical area. And these days, usually your family members can come up there with you, but I would check before your family members come in thinking that they're going to stay up there with you, because with the COVID thing, they're not letting any family members come up and stay with patients right now, today. So, and that could change as we go from phase 3 to phase 4 and so on. So check before your family members come in with you. Okay, so once you're up there, you're going to get off the elevators, you go down the hallway. There's nice big signs. There used to be signs that are like this. Now there's nice big signs hanging from the wall. It tells you where to go. You go to the desk. Somebody's going to get up and take you to your room. You'll be instructed to change your clothes. There should be a bag on your bed, your stretcher. If there isn't, you can ask somebody to bring a bag in for you. Unless you bring your own bag in, then you don't have to worry about it. While you're doing that, then there's going to be usually 2 nurses come in to get you admitted up there. They're going to be checking one's going to check your chart, one's going to be getting your equipment together. There's a whole bunch of stuff that they have to get together. So they'll come into the room. One nurse is going to be asking you a million questions. The other nurse is going to be doing other things. The first thing she's going to do is do vital signs. Then she's going to listen to everything, look at your surgical area, make sure there's no open red areas there. And then she's going to be starting an IV, an intravenous line. As soon as that intravenous line is in, they're going to give you 1,000 milligrams of intravenous Tylenol. That same nurse is going to be prepping your surgical area. We use special clippers to get all the hair off that surgical area, quite a ways up, quite a ways down. We use good old tape to get all the loose hair off. And then once that's done, they're going to be using a special, it's called Chloroprep. It's a bright orange antiseptic solution. Now paint your surgical area with that. That same nurse is going to be doing nasal swabs on you. Now I know when you went through pre-admission testing, you had a nasal swab and you thought it was going to go down to your toes. Well, these are not so bad. They only go in the end of your nostrils. And these are, they're called Profen decolonization protocol. And that's to get rid of any, to cleanse the nasal passage, to get rid of any bacteria in the end of your nasal passages. Because what happens is, in the general population, there's like 30% of the general population that has like MRSA or Staph aureus, and they might have a mild case and they don't even know it, so they don't get treated. So what happens with that is that the bacteria gets colonized in the end of your nostrils. So we try to do everything we can before surgery to prevent any kind of bacteria or getting into your surgical area. So we do everything we can before surgery to prevent that after surgery. Now these nasal swabs contain iodine, so if you have an allergy to iodine, make sure that you tell the nurse, and then they won't use that on you. There's 4 of them. There's 2 that they use each nostril, one back and forth, back and forth. Once that's done and the operating room calls for you, they'll take you over to the operating room. Some of this information that's on here was pre-COVID, so your family members, you know, if they're there, if they do allow family members to come up, they can walk over with you to the waiting area, which is right on the way. We'll deposit them there. Surgeon will come out to talk to them afterwards, if that happens to be the case at the time. If your family members are unable to be present that day, make sure that you give us a number on ambulatory so where the surgeon can call afterwards to let your family member know that everything went okay and where you're going to be going. So we have several goals for anesthesia here. Our number 1 and most important goal is for you to safely experience your surgery. Then we want to proactively treat your pain, and we want, before you experience it, that's the goal. And we want to prevent nausea. So by doing those 2 things, we can optimize your ability to participate. These masks not only give you trouble breathing, but they give you trouble talking. So anyway, by doing those 2 things, we can optimize your ability to participate in physical and occupational therapy. That's very important after surgery. For anesthesia, most people receive general anesthesia, which means you're completely asleep. Now, there may be some reason why the anesthesia person, your anesthesia person, determines that general anesthesia may not be the best for you, and there may be a different kind of anesthesia that they give you. But whatever they give you, you're going to be completely asleep throughout the surgery. For patients having total knee surgery, you'll be going over to the recovery room before surgery to have a block, and we're going to go over that a few more slides down. When you're receiving any kind of anesthesia, you'll be constantly monitored by the anesthesia team. This includes your EKG, which is your heart, your blood pressure, pulse oximetry, which is your oxygen level, and they also keep an eye on your temperature to make sure that that doesn't fluctuate too much up, too much down, to make sure you're safe throughout the whole procedure. Surgery generally takes between 1 and 2 hours. Sometimes a little bit more, sometimes a little bit less, depending on what they find and what they have to do when they get in there. And while the rest of the team is getting you ready to go to the recovery room, the surgeon will come out to, as I said, if at that time they're allowing your family members to come up, he'll come out to the waiting area and talk to them. If not, I don't know at this moment if they're calling people afterwards or not. I will find that out. But so when you wake up, that's where you're going to be. You're going to be in post-anesthesia care unit, PACU, or most people just call it the recovery unit. Once you're ready and all those parameters that we went over, EKG, blood pressure, all that good stuff is good. Any pain that you might have is under control. Any bleeding that you might have is under control. When all that's good, they'll send you up to the 6th floor, which is our nice big private rooms up there, our orthopedic surgical unit up there. And the nurse manager from that unit is going to be coming down after I get done to talk to you. If you want, you can go up to the 6th floor. She'll give you a little tour of the area if that's what you want today, or another day if it's better for you. But she'll be down to talk to you. As I said, if they're allowing any visitors at the time, the family members can go up there at that time. They can wait in the hall while the floor staff is getting you into bed and get you comfortable. Then they can go and visit with you. The body has many different pathways through which pain travels to get to your brain to let you know you're having any kind of discomfort. So our goal is to administer medications before, during, and after surgery to help prevent the pain impulses from getting through those pathways to get to your brain to let you know you're having any discomfort. I'm going to mention some medications. Now, unless there's a reason you can't have them, you're either allergic to them or another reason why you can't have these medications, this is what you're going to get. The Tylenol I told you about is 1,000 milligrams of intravenous Tylenol right after they get your IV in. NSAIDs, non-steroidal anti-inflammatories, they're going to give you 400 milligrams of Celebrex before you go for surgery. Nerve modulators help decrease the impulses of pain. Lyrica, they're going to give you 75 milligrams of Lyrica in ambulatory before you go over. Opioids are the narcotics that they have ordered for you afterwards for any discomfort you may have. Nerve block, we're going to go over for the people that are having the knee done. Steroids, they're anti-inflammatories. They give you those during and after surgery to help decrease inflammation. Inflammation causes swelling. Swelling presses against the nerve endings, and that's what causes most of your pain. So they try to decrease that swelling and inflammation, and so that you don't have that much discomfort. Okay, so here's a block. For those of you that are having your knee done, a block is an injection of a local anesthetic, which is a numbing medication around a nerve to decrease the pain in that joint after surgery. It lasts varying times from 8 hours to 12 hours. I had a block from one of my shoulders one time, and that's when they were keeping the arthroscopic shoulder surgeries overnight in the hospital. They don't do that anymore. But my block lasted like 24 hours. I was home before I started feeling any pain. So it's administered before surgery. It's done in the recovery room. Before they do anything, they're going to give you some relaxation medicine through your IV, and then you're not going to care what they do to you. The anesthesiologist does this. They use an ultrasound machine to identify the nerve that they have to inject. You might feel a little pinch, a little burn while that medication is going in, but because you had that relaxation medication, you're not going to care. It takes about 5 minutes. It takes almost as long to explain it than it does to do it. And once that's done, and because you had that relaxation medication, they're going to monitor you in the recovery room until the OR calls you, and then the anesthesia team is going to take you across the hall to the operating room. Now, this is very important. After surgery, everybody and their brother is going to ask you if you're having any pain. And if you say yes, they're going to ask you to rate it on a scale of 0 to 10. Now, I know a lot of people have trouble giving us a number. So every room up there should have a picture on the wall like this. So if you have trouble giving us a number, you can look at that picture and say, like, I feel like that guy that's a 5 or 6 looks, so I guess my pain level is a 5 or 6. So, your pain level is going to change throughout the day, depending on what your activity level is and how long it's been since you had your last pain medication. It's very important for you to tell the nurse as soon as you start feeling that pain so they can get you medicine in a timely fashion. The reason that they ask you for a number is because the doctor's going to have several different medications ordered for you for pain, mild, moderate to severe pain. And depending on what you tell them your pain level is, they'll give you a medication according to what your pain level is. But the main point is that to tell the nurse as soon as you start feeling pain so that you can get relief quick. Okay, so after surgery, you may see and feel a few things. I don't know if any of you have had any experience with this. This is called an incentive spirometer. Now, you remember that I told you that most people have general anesthesia. So when you have general anesthesia, they have a tube down your throat. You don't know it's there. They put it in after you're asleep, take it out before you're awake. The only reason you'll know that the tube was there is you may have a little scratchy throat. That's because the tube was there. So, because they have that tube down there and you're completely asleep, they give you air, oxygen, and they can give you different kind of medications if they need to through that tube. So while that happens, your lungs aren't working as they normally do when you're wide awake. So this is to reinflate your lungs to keep them expanding normally. Also, when this happens, the secretions in your lung kind of pool in the bottom of your lungs. So this helps those secretions to get mobilized so your body can get them up and out. This is to prevent postoperative pneumonia, so it's very important to do this. Now, I don't know if you can see this. There's a white area here, and then numbers up here. So what you're going to do is you're going to let all the air out of your body passively, and before you take a breath in, you're going to make a nice tight seal around this mouthpiece. And then you're going to breathe in as deep as you can. And while you're breathing in, this white area is going to go up, up and up. So you're going to shoot for like 1,500, 2,000, or more if you can. So you keep doing this until you can get up to 2,000, like 1,500 to 2,000. You may only get up to like 500 or 750 for the first couple times. But each time you want to try to increase the amount of air you take in, because this expands your lungs. It keeps expanding them so you don't get what they call atelectasis, and it also gets those secretions mobilized up and out. You may feel something on your legs. Tightening up on your calf. It'll tighten up on one side and it'll relax. And then it'll tighten up on the other side and relax. And this is called pneumonic compression devices. We call them flotrons. And they're used to keep the blood flowing through your legs to help prevent blood clots after surgery. They're wrapped around the calf of your leg, and you'll have these on during your stay in the hospital. You'll have 2 surgical dressings. The people that are having their knee done, you're going to have your surgical dressing on your knee, and then farther down in your shin, you're going to have a 2x2 dressing. Now, after you go to sleep, they attach the robotic machine to your leg, your shin down there. And what that does is it gives the doctor parameters and numbers, and it helps to align that joint up so that it's in proper alignment when you get up and start walking. And the person that's having the hip done, you're going to have your hip incision dressing here, and then farther up is where that 2x2 dressing is going to go. It's put in that they attach that after you're asleep, taken off before you're awake, so you don't even know it's there, but that dressing is there. Sometimes it bleeds a little bit, sometimes it doesn't. Those are left on usually for 7 days afterwards. And if showering is a major concern for you, you can ask your PA the next day when she comes in. If there's anything they can do that you can shower, because I know my daughter had her hip done. They put an occlusive dressing over it, and she was able to take a shower in 2 days. So if that's a concern, make sure you tell them. Also, I just wanted to let you know, for the people that are having the knee done, when you wake up, you're going to see this bandage. It's an ACE wrap from your ankle up to your mid-thigh. And the next day when she comes in, she'll take that ACE bandage down. Underneath there's cotton, a weight material. She'll take that off. I call it cotton batting because that's what it looks like to me. She'll take that off, inspect your incisions and your dressings, and then she'll rewrap your leg from your ankle up to your thigh. And that's left on usually for 3 days. So I can't express enough how important that is for you to be able to participate in physical and occupational therapy. The more you're able to put into it, the better your outcome is going to be. I'll touch on these quickly because they're going to come in and talk to you too. Physical therapists will see you in the hospital room after surgery with 3 goals in mind. And these 3 goals, plus your blood work, is what determines if you're going to go home that next day. They're going to get you in and out of bed safely. They're going to be getting you walking 100 feet. And if you have stairs to go up, navigate, even stairs to go into your house, they're going to go up 3 or 4 stairs. They have a little staircase on the floor, it's like 3 or 4 stairs. And they're going to go over that to show you how to do that safely. They know that everybody recovers at a different rate. And so they're going to come in and get at your level that you're at, and then they'll bring you up to where you need to go home and to be able to navigate safely at home. The goal is for you to participate in physical therapy starting on the day of surgery with 1 visit, and then at least 2 times, ideally, thereafter. Initially, some patients, you may benefit from pain medicine 30 minutes before your session. Ask your nurse if you can get something 30 minutes before your physical therapy session. Makes it easier for you to walk. Occupational therapy will see you in your hospital room to help you maintain independence, using the toilet, bathing and dressing yourself. Those things sound simple, but once you've had surgery, it becomes a little bit more difficult. So they're going to show you how to do these things safely. The goal is for you to participate in occupational therapy starting the day after your surgery, at least 2 times a day. Physical and occupational therapy, your participation, I can't say this enough, and that's why we've got several slides on this, is very important. It's essential for you to have a successful discharge. So some of you had a dietary consult, some of you didn't. We're not doing the dietary consult anymore. We're going to give you these guidelines to follow, which those of you that have already gone through the program have at home. But these are telling you what are good foods for you to eat, what to avoid, to help your body to heal, because you're going to be needing a lot of healing processes going on after you have your surgery. So read these over. Front and back tells you guidelines, good things, bad things. On the back are some sample menus. So after a day of surgery, you're going to not have anything for quite a while. After that, they're going to start out, they're going to advance you like clear liquids, full liquids. Clear liquids are like tea, Jello, things like that. Full liquids have a little more substance to them, and a regular diet, or therapeutic if you need it, if you're diabetic. Each day you'll be offered choices on a specially prepared menu to fuel your post-operative nutrition. Your goals are for hydration. Drink lots of water, lots of fluids, because you're immobile and you're going to get pain medications. So both of those things tend to promote constipation. So you want to drink a lot of fluids, eat a lot of fruits and veggies, and lean meats and healthy fats to promote healing for you. Okay, so on discharge planning, a social worker is going to be coming in here to talk to each one of you individually. And we'll go over this quickly. Outpatient physical therapy is the most common. They also have home care physical therapy, where somebody comes into your home to do physical therapy. And inpatient rehabilitation, either acute rehabilitation center or subacute rehabilitation center. And those last two things are usually dependent on your insurance, whether they'll cover those or not. Outpatient physical therapy, which is the most insurance, is paid by insurance. And there's a variety of any facilities on the outside in both counties. If you're in Greene County or Columbia County, there's a lot of them over here. Home care physical therapy, Medicare, Medicaid, and most insurance companies have strict guidelines for these. And that's what your social worker is going to help determine today, what your plan is today. And as I said, that can change if something happens on your day of surgery. They can change that. For home care, you must be homebound due to severity of your illness. Weather-related concerns, lack of transportation, or difficulty entering or exiting your vehicle will not qualify you for home care. It has to be another underlying cause. Inpatient rehabilitation, acute rehabilitation, usually is located in a hospital and requires that a patient tolerate at least 3 hours a day of intensive therapy, an hour and a half of physical therapy, and an hour and a half of occupational therapy. And again, eligibility depends on insurance. Subacute rehabilitation center is usually located in a separate unit of a nursing home that allows patients to receive physical and other therapies. This requires a patient to be able to tolerate at least an hour a day of therapy. Eligibility depends on insurance. Please refer to your Total Joint Handbook for instructions at discharge. It has a lot of good information, and that includes surgical incision care, post-operative medications, allowed activities after your total hip, knee, or shoulder surgery, nutritional recommendations, and it tells you when to call the surgeon's office and when to seek immediate attention. It also goes over how to prevent circulation problems. They'll show you how to do, they call them ankle pumps. You do this and rotate your feet to keep that blood flowing through your calves. Before you leave the hospital, make sure that if you have any questions, make sure that you get an answer for them. Like I said, you can always ask your surgeon, your PA, the nurses on the floor. If they don't know the answer, they'll get the answer for you. And we want you to have all your questions answered so that you're ready to go home for discharge. So the healing process is important to allow your body the time it needs to heal properly. You may be tempted to overdo it in the first week because the chronic excruciating pain that you've had all this time now isn't that bad. You have the surgical pain, but that chronic pain is better. So you say, oh, I'm going to do this, I'm going to do that. It's crucial to moderate your activity to what the surgeon and the therapist tells you to do. Keep in mind that it's normal in the second week for more swelling and more pain because certain pain your body's pain control mechanisms wear off after that second week, so you have more swelling and more discomfort. So if you try not to overdo it the first week, that helps to decrease that in the second and third week. Okay, icing is very important. Icing your surgical area regularly is important to help reduce that inflammation and that swelling so that it doesn't press on those nerve endings. When you leave the hospital, you can ask for extra ice packs before you go home. Just remember that those ice packs, they're good until they fall on the floor because then the seal breaks inside and you get all wet. There's a number of things. You can use Ziploc bag with ice cubes in it, bag of peas, those things that you buy at the drugstores that you put in the freezer. They also, the doctor's office offers these ice machines. They're special ice machines, and the surgeon's office offer them, but they're $150 and they're not covered by insurance. But they are very convenient. You can fill them up with ice and water, and there's a cord that goes from here to the wall. Keeps the ice flowing through the tubing. There's a different attachment for each surgical area that's being operated. So you order it, and then you just get the attachment that goes with this particular surgery that you're having.
I just wanted to mention, which I think I've mentioned to you before now. I was told by a previous person who had the operation like corn syrup. You put corn syrup in a Ziploc bag and then put it in another Ziploc bag, put it in the freezer, and use that. And have several of them because it doesn't freeze entirely and it really does.
And you can mold that on.
To your needs.
That's good. Anything that works for you is good. Some people like this because it's convenient, because you can fill this up. It lasts for 8 hours. And some people tell me if this is what you're interested in and you want it, they take a big container and they fill it with water, something that's going to fit right in the inside of here. Put it in the freezer, freeze it so it's a solid block, because a solid block takes longer to thaw out than just ice cubes do. And it lasts for 8 hours. So it's a convenience thing. But still, you want to make sure that whatever you use, you only use it 20 minutes on, and then you want to take a break for at least 20 minutes. Use it 4 to 6 times a day or every hour if you can think about it while you're awake. For those first 2 weeks, first 3 weeks maybe even, that was very helpful for my husband when he had his knee surgeries. I don't know about you, if the ice was helpful to you, but it was to him. I say the ice is your best friend after surgery, or anything that works for you. So the stretching and exercise, remember it's quality, not quantity. Do the best to complete these every day, and as shown to you. If you ice and stretch properly, back on the stretching and exercises, quality and quantity. I had my shoulders done. So you go to physical therapy, and they give you exercises. You do the exercises while you're at physical therapy. They give you exercises to do at home. So my theory was, okay, I got to do 20 of them. So I'm going 20, 20, 20, But that's not what they want. They want you to do it the way they show you, so that's the quality versus quantity, So do it the way that they show you, and you have to make sure that you do your exercises in between your physical therapy sessions. If you ice and stretch properly, along with taking it easy, your healing is going to be the best overall that it can be. Oh, okay, I guess we're at the end. Any questions?
So I just wanted to introduce myself. I'm Annie Trowbridge. I'm the director of the 6th floor, which I don't know if anybody has talked about the 6th floor, but that's where you will come after your surgery. So generally, everything is pretty much done ahead of time, as you know, and has been told. When you come to the floor, we get you up 2 hours after you reach the floor, or if you need a little more time, whatever, we kind of assess things, make sure you have your legs underneath you and those kind of things. Physical therapy and occupational therapy get you out of bed first. If you come up late, our nurses will assess you and try to get you out of bed. That's our number one goal, is to get you moving, get you comfortable with what's going on. You'll have walkers. private room. You'll have a commode if you need it, or certainly a bathroom in your room, which we prefer that you get started right away. There's always nurses and PCAs, assistants to help you with anything you might need, but we try to get you moving. If you've decided to go to rehab, we get you prepared for that. You'll have some blood work. We'll get you fed right away. Fluids usually come right down. So we get you moving and recovering the minute you hit the floor. So, so thoughts of, I'm sure you've been asked to think about if going home. We'll ask you all of those things about stairs and whatever. The PTOT tests you. We have stairs on the floor that we use. If you're going to rehab, we get it set up. Usually we have a couple of places or recommendations that you share with us, and we start right away to do that. A couple of things that we have to do now based on the pandemic is if you do go to nursing home, we will have to test you for COVID-19 within 24 hours of a discharge. So we'll be thinking about that. We do some blood work because we make sure that if you've lost any blood in the OR, that we will, your body accepts that and starts to recover from that. So we'll make sure you're as stable as you can be when we take you out the door. So with complete instructions, although you have the packet, we also have discharge instructions. Your appointments will be made for you. Medications will be where probably before you come in, they've already been called and perhaps even picked up. So we're real proud of this program, and we're just the last leg, if you will, of your hospital experience. So I'm always pretty much on the floor. My nurses are super with recovery of your joints, and we're here to help you and get you on your way. Any questions? Yes?
I've had the visiting nurse service come in a couple of days, a couple of weeks of therapy.
Oh, that's great.
I got a telephone number and it's busy every time I call. I don't know.
Oh,
Social workers are coming today too to help.
yeah. I
Yes,
think Bev is coming at 11, so
Yeah.
there'll be a social worker here to help you with that, and maybe verify the number that you have, or we can even help you with that call.
They'll get
But
that
that's a
started.
great idea. Yeah.
They'll get that started today. That's why they.
Yeah. Physical therapy is extremely important, and some of you will just follow up in the outpatient setting, and that's fine. But the physical therapy part, it's hard to imagine that you wouldn't want to talk yourself out of getting up and doing a walk around your house or whatever. Extremely important to keep that joint moving, working, greased up, and so that's and if you have somebody come into your home or whatever to push you a little bit, that's golden. So it's a good idea. Yeah.
I have surgery scheduled for Monday,
Yeah.
and I have an appointment Thursday with the physical therapist. I go to their office.
Yeah.
Okay.
Yeah.
So what would you, I know I'll probably be in the hospital till Tuesday.
Yeah.
At least the one night,
Mhm.
correct? Yeah.
Yes.
If I am discharged and all, is there a recommendation for what I should do on Wednesday? Just follow the guidelines?
Yep. And physical therapy, our physical therapy and occupational therapy will show you
I'll get
what
more
to do.
information then. Okay.
And yep, and they'll show you how to get up. Are you having a hip or knee or knee?
Knee,
Okay.
yeah.
They'll show you exactly how to position your leg to get up, stand up, lay down, whatever. They're extremely
I
good.
have a script from the doctor already
Yep.
as to what his recommended protocol is.
Mm-hmm.
So
Yep.
I'll have that for them when I go there.
Yes.
But
Yeah.
I'll follow what I learned from you folks.
Yeah. Just for
in the
those couple of days, what basically what we would do before you see physical therapy is keep you safe and keep
Okay.
that, we won't want you to be doing, too much. But we will want
That's my
you.
initial thought.
Yeah.
But then what I heard Linda said before, quality, not quantity.
Yes.
So yeah, so you want to,
yeah.
I got it.
So, and they'll tell you, get up from a chair, walk around your house a bit.
Okay.
It's important, if nothing else, to keep your lungs healthy
Right.
and moving. So, yeah. I think you'll be very pleased, and we welcome you and hope you have a good experience.
Okay, thank you.
You bet.
All right, welcome. I know your nursing already introduced you. My name is Jill. I'm an occupational therapist here in the hospital. I'm representing OT and PT today, so I'm going to cover what PT is doing and what occupational therapy is going to do for you when you come into the hospital for elective surgery. You'll be admitted to the 6th floor after your surgery. Physical therapy's goals is to see you certainly on the day of your surgery, if it's at all possible, and depending also on how well you're doing afterwards. We want to get you up and moving and into a bedside recliner as quickly as we can. The next day, we come around again. Physical therapy will try and see you 3 times. That's their goal, see you 3 times. And occupational therapy will come in for their evaluation and try and treat you twice a day. I'm going to cover hips last because they're the ones with the more precautions, and there's no shoulder replacements today. So again, our goal is to get you up and moving. If you have adaptive equipment at home, like you have a walker, bring it in with you. Recommend the hip patients get a hip kit if you don't already have a reacher and a sock aid, all that sort of stuff, and I'll go over that with you because you have precautions that you don't want to break. We'll get you up. The reason why we use a walker, even though you may not be using a walker now or a cane, is because we want you to start to practice a normal gait pattern and get you back to moving normally. Things are probably been a little crooked and a little off for a while. And then we discuss where you're going to go. Most people are going home. And they're going home same day of surgery, not necessarily for hips, but generally speaking, as long as you're comfy, as long as you have support, and you can do the things you need to do. So when you go home after today's session, it's important to go and look at your house, look at your seating surfaces, make sure you can get in and out of those chairs. Well, again, you're sort of a special party of that because you're already good at, all right, this is great. Okay, so you want to do that. You want to pick up any slip rugs. You want to look around for any places that are hazardous you could possibly trip. You want to look at your tub or your walk-in shower or any of the places that you've got to routinely get in and out of. We're going to cover bed mobility. We're going to cover getting in and out of the bathroom. We're going to cover getting in and out of cars. We can't obviously get in and out of cars, but we're going to walk you through it and tell you how we're going to do it. Knees, generally there's no adaptive equipment. Occasionally somebody has a little bit of difficulty where they can't maybe lift their leg onto a bed, and we'll show you those strategies, but it doesn't involve usually buying anything. We just want to get you back moving as nicely and as quickly with least amount of compensatory strategies, and then get you to the outpatient clinics or home clinics, whatever it's going to do for you. Any questions? It's pretty straightforward and it's really lovely. 6th floor, I don't know if you've been up there, great view of the Catskills. It's a nice, relaxing, lovely place to be. So, if that's okay, I'm going to address what we do with hips, okay? I guess since we're filming, I'll just do the whole thing. With hip precautions after your surgery, there are 3 things that you can't do. Can you remember what they are?
Bend more than 90 degrees.
Lovely. That's the most important one. Anything that puts pressure on that area of surgery.
Sitting straight chair. I have a recliner that is electric,
Right.
and I haven't slept in the bed until almost 4 years.
Super. So that's important for us to know because we don't want to make you do anything you don't do. But cementing those 3 hip precautions in your head is really important to prevent any dislocation. Again, we're going to use a walker. You have a rollator. Chances are we're going to let us work with just one of our regular walkers, okay? Because they're slower, it gives you a chance to practice walking and stuff like that. And again, are you planning on going home?
Yeah.
Okay. So provided you look around the house.
Mobile home.
Okay.
I don't have any steps.
Lovely.
My landlord put a ramp in
Okay.
when I moved there.
Excellent.
I have a stall shower with
Awesome.
a seat in
Right.
it.
You're set and ready to go. So you're probably going to teach us a few things while you're here,
No.
which would be fine. All right, so in front of everybody is an exercise packet. Used to be years ago, they put you on CPM machines for knees. They didn't do that for hips, but you know, they really kept you moving. What they found out over the years is you want to do some movement, but it's very simple. You just want to stretch one way and you want to stretch the other way because you don't want too much inflammation because that's going to limit your mobility. So in that booklet are just some simple exercises. One thing I will tell you, when you're upstairs, when the heads of the beds go up, the feet go up. For knees and hips, also important because of that 90-degree angle, you want to make sure you put the bottom of that bed down so it's flat. And we'll teach you strategies on how to gently stretch your leg using gravity and stuff like that. Ice is available at all times upstairs for both the hips, the knees, and the shoulders. And as I say, we just want to keep you in the least amount of pain and keep you moving as quickly as possible. Okay? And we'll see you all up there. All right. Did I cover everything? All right.